Okay, so I had problems again recording, so I'm doing this again at home. For those of you who weren't in class, remember there is an exam on Sunday. So, assessment of fetal well-being. So, we can monitor babies, usually beginning at 28 weeks with some of our fetal assessment, fetal well-being tests. And it tells us that fetal hypoxia, if we have a fetal hypoxia or a growth restriction or some sort of utero-placental insufficiency for a baby. But one of the most common, easy to do at home for the patient tests to do for fetal well-being is fetal movements or fetal kick counts. So sick babies don't move. So if we want to know how well baby is doing, we'll have mom do fetal kick counts. So a fetal kick count is the woman counts how many movements there are in a 2-hour period. So less than 10 movements is significant for having the patient come in to be evaluated on a fetal monitor. Or another thing we can do is, so how much does your baby usually move every morning at 10 a.m. or every night at 10 p.m.? So every day and every week, that should be the norm for the baby. So if baby moves 6 times at 10 p.m., 1 week, baby should move 6 times at 10 p.m. the next week or the next night even. So significant changes in baby movement in that hour would be important for us to have her come in and be evaluated on the monitor. Ultrasounds are other common ways that we check on fetal well-being or other things about the pregnancy. So we can do an abdominal ultrasound or we can do a vaginal ultrasound. The vaginal ultrasound many times is done to visualize the cervix in addition to the baby and or placenta. But a lot of times the vaginal ultrasound is used to evaluate the cervix. So there's many things that we can do when we're doing a maternal ultrasound. So we can estimate gestational age, and the earlier we do this in the pregnancy, the more accurate our estimation of gestational age is. So for instance, in early fetal development, the size of fetuses in the first 8 to 10 weeks is usually the same in all fetuses. However, growth rates differ tremendously after that, depending on the health of the woman and the health of the baby. So the earlier the ultrasound is done, the more accurate the gestational dating is. Also, with ultrasound, we can measure and estimate baby's weight and size. So we will measure the biparietal diameter of the head, the femur length, and then estimate the weight of the baby. We also can screen for fetal anomalies, specifically Down syndrome. So we can detect cardiac defects. We can measure amniotic fluid index. So an amniotic fluid index is when we take the uterus and we divide it into 4 quadrants and we measure the deepest pocket of fluid in each one of those quadrants and then add that sum. We can look at the placenta, determine the health of the placenta and the location of the placenta. We can determine fetal position and what is the presenting part in the pelvis. And then, of course, we can detect fetal death. So to detect fetal death, we need to visualize that on ultrasound. So if I'm trying to get fetal heart tones with my monitor and I can't find fetal heart tones, and I've tried and tried and tried in every possible place on her belly and I still cannot find fetal heart tones, that is not the official determination of fetal death. So we need to have the ultrasound to determine fetal death. Other tests that we can do for fetal well-being is the Doppler flow study or the umbilical velocimetry. So these are not done routinely. These are done when we need to determine, because we have a baby that has some sort of intrauterine growth restriction, and we feel we have a functioning placenta even, we want to see how the umbilical cord is doing on blood flow. Do we have a problem with the umbilical cord? So usually we talk about the problem with oxygenation through the placenta, but then we may have an umbilical blood flow issue as well. So this is done by ultrasound. They're looking at the blood flow in the vessels of the umbilical cord, which display as a waveform. And this waveform, the highest peak of this waveform is the systolic pressure or systolic measurement, and the lowest point is the diastolic measurement. And then they record those as a ratio, systolic to diastolic ratio, and depending on the value, they determine whether or not the blood flow is adequate. So a normal SD ratio at about up to 20 weeks is about a 2.0. Then it increases to a 3.0 after 30 weeks and should stay around 3-ish or above throughout the remainder of the pregnancy. So if we have poor Doppler studies, that could tell us that certainly we have an SGA baby or an IUGR baby. If the blood flow is not adequate through the cord, then we are going to have babies that are small or growth restricted, of course. Okay, so typically these babies will not tolerate labor, will require a C-section, will have low APGAR scores, will have respiratory problems after delivery, and ultimately be admitted to the NICU. Now, the major test that's done more routinely than any other test is the non-stress test. This test evaluates fetal well-being by determining the oxygenation status and uterine placental efficiency. So it requires the woman to be placed on the electronic monitor so that we can record the fetal heart rate. These tests can be done in the clinic or in the doctor's office if they own a fetal monitor. Some doctors do, some doctors don't. Sometimes they own one, but they're too busy to do this test, so they send the patient to the OB unit. Anyways, these tests are easy, they're non-invasive, at times they can be quick to perform, they can be easy to interpret, and then there's no side effects, like it's non-invasive. However, I just said that they were quick and easy to interpret, except for when they're not quick and not easy to interpret. So if you have a baby that you're having a difficult time tracing, then you might have a difficult time interpreting the data. And if you're having a difficult time tracing baby, it might take you much longer than 20 minutes to get a decent continuous tracing where you can evaluate this test. So as I said, it requires us to put the woman on an electronic fetal monitor and recording the fetal heart rate. And specifically, we're looking for fetal heart rate accelerations as they relate to fetal movement. Or some of the standards do say that we don't necessarily need fetal movement, we just need the fetal heart rate accelerations. So we position this woman in the triage bed, either in a left tilt, semi-filers, or side-lying position. Of course, we avoid the supine position because that's just not how you do not lay women on their back. So the best blood flow, as we know, is to be on the left side with the weight of the uterus off the vena cava. So what we need to determine whether this baby passes the test is we need at least 2 accelerations, and accelerations by definition have to be 15 beats above the baseline for 15 seconds, and we need these 2 accelerations in 20 minutes. It is not good enough to have 2 accelerations in 30 minutes. We need both accelerations within a 20-minute period. Now for preterm babies, we will do the 10 beats for 10 seconds acceleration, okay? Now, if we get those accelerations in the 20-minute period, then baby has passed the test, but we don't report that as baby passed or baby failed. We report that as a reactive non-stress test. So reactive meaning a positive thing, meaning yes, reactive, it's present that the baby has non-stress or no stress. So this is kind of confusing, but you need to really try to understand this, because when we get to another test, it's going to be the exact opposite. So reactive means yes, it's positive for non-stress test. Okay? So if baby passes the test, it's a reactive non-stress test. Baby is not stressed. Now another important thing to alert you on is, so between 28 and 32 weeks, babies can or cannot pass this test, and it'll be okay. It's because their central nervous system is not mature enough to respond in this way. So the parasympathetic and the sympathetic, which is what causes low heart rates and high heart rates, okay, that system, that central nervous system is not mature enough to react this way. So for instance, if a woman comes in at 28 weeks and she cannot pass this test, or she cannot display a reactive non-stress test, we don't necessarily say that we have a problem with our baby. We will have to do another test to determine if our baby is okay. At that time, the baby may not have been mature enough to pass this test. But on the other hand, if that baby comes in at 28 weeks and passes the test at 28 weeks, baby should always be able to pass the test. Baby should be able to pass the test at 30 weeks, 32 weeks, 36 weeks, 40 weeks. Baby should pass this test unless something's wrong. So if baby comes in at 28 weeks and passes the test, great, baby's doing good. If baby comes in, that same baby comes in at 30 weeks and does not pass this test, then this baby has a problem. Okay? So anyways, if we do not get our accelerations that are 15 by 15, then we have determined that we have a non-reactive, non-stress test. Okay? So that means that our baby is stressed. It's really kind of confusing, but try to get this in your brain, okay? It shows on this screen that we have fetal movement. You can look in the lower part of this strip. FM stands for fetal movement, and you can see the baby's heart rate above that, and we have no accelerations. So this is a non-reactive, non-stress test, meaning that baby is stressed, okay? So when we pass the test right here, we have fetal movement, we have accelerations, we say that this is a reactive non-stress test. So baby is positively non-stressed. Here we kind of have the double negative, so we're saying non-reactive, meaning not positive non-stress tests. So if you can kind of try to understand that, that means that our baby is stressed. It's not positive non-stress tests. So she is stressed. That is confusing, but you will see compared to this other test how they're kind of different. So an unsatisfactory test would just be that we could not interpret it, like we either didn't have enough fetal activity or we did not have enough tracing to be able to determine what was going on with baby. Now, a contraction stress test is just that. We need to see if baby is stressed during contractions. So we don't do this test very often. So if baby doesn't pass her non-stress test, we don't then go to the contraction stress test and see how baby does. The contraction stress test is typically reserved for the patient that we want to induce into labor, and we need to see if baby is going to tolerate the stress of labor. So we will induce some contractions and determine baby's ability to deal with those contractions. So we have a baby that's borderline, we need to do an induction, but the woman really would like a vaginal delivery. So we're going to see, well, we have this baby that's borderline that doesn't look so great. Don't know if she's going to tolerate labor. Well, let's see how she tolerates a few contractions. And then that will tell us whether or not that we have good placental perfusion and if our baby is stressed or not. So the problems with this test is they're time consuming because she's in the unit, we have to start an IV, we have to cause her to have contractions. That's either through the use of Pitocin or nipple stimulation, and then we interpret the test, and then we need to wait until those contractions dissipate if that's indeed what we want done, or we will go ahead and just induce her. So this can be a time consuming, and usually if we're concerned about baby, we will just do the induction and see how baby does. If baby makes it through labor, great. If baby doesn't make it through labor, then we go to C-section. It wouldn't matter if we did a contraction stress test or not. Our outcome will probably be the same. Okay, so and also a lot of places don't do this test, especially if they're a small community hospital and they don't have the resources to deal with the outcome of a poor test or deal with the risks of conducting this test, which we will look at. So there are a few patients that you never, ever, ever want to do this test on. And this is a third trimester bleeder with a placenta previa. So if you remember, placenta previa is the placenta is covering the cervix. That woman cannot have a vag delivery. Period. End of story. So why do a contraction stress test when she's not going to have a labor to begin with? So no. So here you can see several reasons why we would not do a contraction stress test. Here are a few more reasons we would not do a contraction stress test. Okay? If you have any questions about these, please let me know. Now, when we are performing a contraction stress test, we need to have contractions. So if the woman is spontaneously contracting, that's perfectly fine. We will take spontaneous contractions, but typically that is not the case. Typically, we have to induce contractions, and we either do that by Pitocin or breast stimulation. Now, the quickest route is to go Pitocin, but some women are like, no, I don't want Pitocin, so then we will instruct them how to do breast stimulation. So once we have started achieving contractions, this is what we need. We first need a 15-minute baseline before we start doing anything. We need to know what the uterine activity is. We need to know what the fetal heart rate is before we start. Okay? Then we start. So say we're using Pitocin. We need to run the Pitocin, and I'll tell you in the next slide the criteria for running the Pitocin. But our goal is to get 3 contractions that last 40 to 60 seconds in a 10-minute period. When we get that, then we conclude the test and we interpret the test results. So when we're running Pitocin, so in labor, in real labor, when we run Pitocin to induce labor, we run it at 2 milliunits per minute. And we increase it every 30 minutes by 2 milliunits per minute if we need more contractions in labor. Now, compare that to how much we're giving here just to perform a contraction stress test. We're using 0.5 milliunits per minute. We are increasing that every 15 to 30 minutes, and I'm actually increasing it every 15. I want to get these contractions I want to get these 3 contractions as soon as I can so I can interpret it as test, and then we can move on with whatever our plan is. If we don't use Pitocin and we do breast stimulation, it can either be manual breast stimulation or she can use an electronic breast pump. So what we do is we do the manual stimulation, the electronic breast pump, for 2 solid minutes, and then we stop for 2 to 5 minutes, and then we go for 2 minutes, and then we stop for 2 minutes. Okay, then we would do that. We would do that routine 4 different times, and then try to evaluate whether we have contractions. We want to be careful, though. We need to take our breaks as they're scheduled, because we do not want to cause, I'm sorry that this word is still in there, hypersystole. So that's not the term we use anymore. We use tachysystole. And if you remember, tachysystole is when we have more than 5 contractions in a 10-minute period, or we're contracting more frequently than every 2 minutes. So that's why when we're doing breast stimulation, especially, that we're doing it for 2 minutes and we're taking a break, and we're doing it for 2 minutes and we're taking a break. So we get the good quality, we get the 3 good quality uterine contractions, 40 seconds in a 10-minute period, and there are no late decelerations. That means that she has passed the test, that baby is good, but that's not how we say it. So we say it as a negative contraction stress test. So she is negatively stressed with contractions. So negative contraction stress test is good. Now, if she has a negative contraction stress test, then we know we have good uterine placental sufficiency, we know we have fetal oxygenation, and we are saying that the baby will likely withstand the stresses of labor. So we could go ahead and induce her. However, if she has a positive contraction stress test, that means she is positive for stress during contractions. That means that she's having late decelerations with her contractions. That means baby will not tolerate labor. That there is some sort of uteroplacental insufficiency, there are decreased oxygen reserves, this baby is not well enough to tolerate labor. So you can see from this slide that we have actually 4 contractions, and with each and every one of these contractions we have a late deceleration. And it does appear that we have moderate variability. Moderate variability is a good thing, right? Moderate variability tells us that our baby is oxygenated. So when baby is not being stressed and baby is just laying in there doing absolutely nothing, baby is getting enough oxygen. But the second there is any type of stressor, baby is having a late deceleration, telling us that there is a huge uteroplacental insufficiency where baby is not getting oxygenated. So this baby cannot tolerate a labor. So an equivocal test or a suspicious test is that we don't have consistent late decelerations, but maybe inconsistent. So we have one here and maybe one not with this contraction and maybe one here, or we have a significant amount of variable decelerations. Also, if we have hyperstimulation, that means that we have that we're contracting more than every 2 minutes, and that our contractions are lasting longer than 90 seconds with late decelerations. Well, that's obvious because we're overstressing this baby. Even a healthy baby may not be able to tolerate that frequency of contractions at that amount of time. So it's inhibiting oxygenation to the baby. So we got to make sure we do not have a hyperstimulated, I'm sorry, I'm not supposed to use that word, a tachysystolic contraction pattern. Okay? So just like with the non-stress test, the unsatisfactory is we couldn't interpret the test. We had poor tracing. We could not, no matter what we did, get an adequate contraction pattern. So we need to go to plan B and try to decide or do a different type of test to check on baby's well-being. So with the non-stress test and with the contraction stress test, we are, as the nurse, interpreting those results. There's no physician coming in and checking behind us. We are the ones that are putting the woman on the monitor. We are implementing the test. We are starting the IVs and running the Pitocin and leading the breast stimulation or whatever we're doing. We're the ones that are getting the tracing, and then we're the ones that are interpreting the results, and then we are calling the physician and saying, this is the results of the test. We need to send her home, or we need to keep her, or we need to do whatever we need to do. Okay? So like I said, typically the non-stress test is done very often. It's very routine. We do them all the time on lots of patients, several different times. So non-stress test is very easy, very simple to do, non-invasive. We do it all the time. But when we have a non-reactive, non-stress test, so our baby did not pass the test, then we need to maybe use some other test to see more specifically about how our baby's doing, or maybe we could not interpret the test. We didn't get enough tracing or whatever, so we need to do another test to check the baby. This is the other test we will do, the biophysical profile. There are 5 parameters to this test. One of those parameters is a non-stress test. So we did the non-stress test in the OB unit. They passed or didn't pass, but typically they do not pass, so we send them to ultrasound. Then we have the other 4 variables to this test performed in ultrasound. And these are those other parameters. Fetal breathing movements. We need at least 1 fetal breathing movement for 30 seconds. Fetal body movements. So we need at least 3 fetal body movements. Baby needs to demonstrate tone. We need to have 1 episode of full extension and full flexion. And then we need to have the amniotic fluid volume being within normal, or we need to measure the amniotic fluid volume, so it's either normal or it's not normal. But anyways, as I said before, actually the amniotic fluid index is where we divide the uterus into 4 quadrants and we measure the deepest pocket in each quadrant. Okay, so 5 to 20 centimeters is about the normal. So baby has 30 minutes in ultrasound to demonstrate each one of these parameters. If baby doesn't demonstrate these parameters within 30 minutes, baby will get a bad score on these parameters. So we'll talk about scoring in just a minute. So this does also help us identify fetal well-being and the placental sufficiency. Okay, so as I said, the ultrasound portion of this exam takes 30 minutes. So for each one of those parameters, for each one of these parameters in ultrasound, the baby either does these within 30 minutes or does not. If baby does these in 30 minutes, they get a score of 2 for each one of these parameters. If one of these parameters the baby does not accomplish in 30 minutes, baby gets a score of 0. So that's the 2 possibilities. For each parameter, it's either a 0 or a 2. Now, if we've already done the non-stress test in the OB department and baby did not pass the non-stress test, in other words, baby did not have a reactive non-stress test, baby gets a 0. So baby already has a 0. So then they go to ultrasound. Each one of these other parameters are tested, and then baby is scored. Okay? So the maximum score is 10, right? Because there's 5 parameters, 4 in ultrasound, 1 in OB, a score of 0 or 2, so 10 is the maximum score. So babies who score between 8 to 10 are considered to have passed this biophysical profile, as long as they do get full credit for amniotic fluid. Okay. If they score less than 8, then there needs to be a discussion with the OB provider as to what we are going to do now, because this is telling us that we do not have an oxygenated well baby. So does this patient get admitted to the OB unit and on constant continuous monitoring and observation for as long as we can keep her pregnant, or does she need immediate delivery? So a patient that scores a 6 would probably be one of those patients that we might sit on for a little bit, especially if she was preterm. We would do continuous fetal monitoring to watch this baby minute by minute, 24/7, and if the baby hiccuped wrong, then we could do delivery. If the baby scored, up to 4, 0, 2, or 4, that is pretty much an immediate delivery. Okay? So other things that we can do to determine fetal well-being is fetal lung maturity test. Now, before I explain this to you, because there's 4 different fetal lung maturity tests. Before I explain this to you, back in the day, before we had recommendations from ACOG and A1, those are the national governing bodies for OB, back before we had them come out and say, you cannot induce a woman before 39 weeks unless you had a medical or obstetrical reason. So back in the day when we could induce anybody at any gestational age for any reason at all, we would do fetal lung maturities. So for instance, we have a woman come in at 35, 36 weeks, and for whatever reason we want to do an induction on her. Say her husband is going off to Iraq and he leaves in a week, so we need to get this delivery done before he gets deployed. Or she's having a very miserable pregnancy. She's having a lot of swelling and a lot of pain. It doesn't matter what the reason is, but we want to induce her before term. So she's at 35 or 36 weeks. We were required at that time to check fetal lung maturity. So if we checked the fetal lung maturity and it showed that indeed we did have lung maturity, we can induce her whenever we wanted. But if we could not demonstrate fetal lung maturity, then the rule was you can't do the induction unless there was a medical or obstetrical reason. So that was the rule back in the day. If you wanted to induce early, you could, but you had to demonstrate fetal lung maturity. If you could not demonstrate fetal lung maturity, then you had to have a medical or obstetrical reason. Now today, the reason why we don't do fetal lung maturities anymore is because we are not allowed to induce women before 39 weeks or before what we considered a reasonable term well baby gestational age. If we had to induce before 39 weeks, we had to have a medical or obstetrical reason. So if we're inducing at term, it's not an issue, okay? But if we're inducing before term, we have to have a medical or obstetrical issue. We cannot induce before term and do a fetal lung maturity today and say, oh, well, we have mature lungs, so we can induce before term. No, we don't do that, okay? You have to have a medical or obstetrical reason to induce before term. That being said, I'm going to tell you about fetal lung maturity, and you'll never see one of these probably in your nursing career. Well, you might. I'm not going to say never, but you might. I've worked in Missoula for about 4 years, and I've not seen one done since I've been here. So, anyway, so fetal lung maturity. So, lecithin sphingomyelin ratio. So, these are components of surfactant. And where we will do an amniocentesis, we will pull out amniotic fluid, and we will test it for LS. Okay. Now, early in pregnancy, the sphingomyelin is a higher concentration than the lecithin. And then that kind of switches as baby gets closer to term and the lungs start producing surfactant and become more mature. So, that being said, lung maturity is an LS ratio of 2 to 1. If we have an LS ratio of 2 to 1, then we have fetal lung maturity. Now, the other test is this fluorescence polarization test. So when they were doing fetal lung maturities, they started trending towards this test and away from the LS ratio test, because most of the time you had to send that LS ratio sample to a lab outside of yours. So it was a send-out lab. And it took 12 plus hours to get your results. These results come back in 30 minutes. So, fluorescent polarization measures the surfactant to albumin ratio, and any test above 50 is mature lungs. However, if the woman has diabetes, her number needs to be above 55. Now, the phosphate diglycerol test, or PG test. So this phospholipid is present in surfactant. So if we have surfactant and mature lungs, it's present. If we don't have surfactant and we don't have mature lungs, it's not present. So when you do this test, it's either PG present or PG not present. And if it's PG present, then we have fetal lung maturity. The last one is lamellar body counts. This is also on the amniotic fluid. So we are looking for these lamellar bodies. If they do their counts and then we have over 32,000, then we probably have lung maturity. So that being said, we don't do those much anymore. But we do a lot of other things with the amniotic fluid. So one, we do the fetal lung maturity, which we don't do anymore. And then we do the triple screen, which tests for fetal anomalies, okay, and the quad screen. So in the triple screen, these are the three components that we're checking for: the alpha fetoprotein, the HCG, and the unconjugated estriol. Now, depending on these values, tells us whether or not this woman is at risk for a congenital anomaly, mainly Down syndrome, and also neurotube defects. So the quad screen adds the dimetric inhibin A, or dimeric inhibin A, and that is a serum test. It does detect a trisomy chromosome problem, and they're saying that this test will probably replace the triple screen sometime in the near future. However, these are done early in pregnancy, somewhere around 16 weeks, and it will tell us whether we have a problem with our baby. Now, some women, this is an elective screening or elective test. Women do not have to have this test, even if they're at risk for a baby with a congenital anomaly. They don't have to do this test. They can refuse it and say, if I get a baby with a problem, I get a baby with a problem. Or they could do this test and say, well, I do want to know if I'm going to have a baby with a problem so I can start getting prepared to care for this child, or I want to know if I'm going to have a baby with a problem so I can terminate the pregnancy. Now, chorionic villus sampling, or CVS, is another test that we can do. It's a genetic studies test. We do these early in the first trimester, between 10 and 12 weeks. This is also an elective test. This is something that we would offer to families with known family history of genetic disorders, or if they had a previous pregnancy with a genetic disorder. These are elective, so like even if she was high risk, she does not have to do this test. She can say, you know, it doesn't matter what I have, I'm going to keep this pregnancy, I don't need to know, or I do need to know so I can get prepared, or I do need to know so I can terminate this pregnancy. Now, this test can be done abdominal or cervical. The risks are the same for the baby either way. However, if we're doing this test cervically, then we're going to run the risk of just some benign spotting. You know, she might have a little bit of bleeding just because we were messing with the cervix, but that's okay. Now, like I said, we can do these as early as 10 to 12 weeks. Amniocentesis typically are not started until after 16 weeks. However, they can actually start as early as 12 weeks. But the big problem with doing a chorionic villus sampling is that we can cause a limb reduction in the baby. So you can imagine if we're doing this at 10 weeks or 12 weeks, how small this fetus is. We've got to get to that placenta to get a sample, and we might accidentally hit the baby. And at that age, a needle hitting a baby could actually sever a body part. That's how small they are. But anyways, so that's one of the big risks. And then the other problem with this test is they do not detect neurotube defects. So here's some additional risks for doing a CVS. Okay. All right. Now, let me move on to the last chapter, which I did not get to lecture on at all today, and so this is the first recording of it. So we're talking about gestational problems, which the big theme here is bleeding. So first of all, abortion. So we have talked about abortion before. So that's the termination of a pregnancy before 20 weeks, whether it's elective or spontaneous. That's the major cause of bleeding, is an abortion. Okay, so spontaneous is it's occurring naturally. Induced means that we're making it happen. Now, the problem with calling a spontaneous loss or termination of pregnancy an abortion is it's very offensive to the family. So they don't consider it an abortion. It was a miscarriage. So we need to be careful with our terminology around the family. But technically, the technically correct term is an abortion. So there is several different types of abortion. The threatened abortion, where there's a partial or complete expulsion of conceptual products. The baby, of course, is in jeopardy. It's going to probably happen. Okay, very similar to our imminent or inevitable abortion. We have a lot of bleeding, a lot of cramping. It's coming type of situation. The complete abortion is all products are expelled, and that's important because when you compare it to an incomplete abortion, where some of the products are retained, those retained products will cause bleeding and or infection. So the missed abortion is the baby has died but has not expelled. So they're saying if the baby is retained beyond 26 weeks, then the woman is at risk for DIC, which we have discussed as a very, very bad thing. But in my personal and professional opinion, shame on anyone who allows this woman to retain a baby that has passed for up to 6 weeks. So we do try to let these women pass this pregnancy naturally. However, we don't want to wait 6 weeks. That is emotionally traumatic. It sets the woman up for bleeding, for infection, and for DIC. So if she hasn't delivered that baby within a week or two, then let's step in and help her out. Okay. So, a threatened abortion, so the baby has died. There is bleeding. Part of the placenta has broken away. Part of the products may have been expelled. The imminent, so the placenta has basically completely broken away. There's massive, not massive, but there's large amounts of bleeding, and she is definitely in the process of aborting. So, or incomplete, so she passed the baby, but she did not pass the placenta. She retained the placenta, so that is a bleeding problem. Okay. Other categories are recurrent or habitual. Don't use habitual. That has a negative connotation, like the woman is doing it on purpose. Use recurrent. So this is 3 or more consecutive abortion. 3 or more consecutive abortions. Okay. Septic abortion. So the woman, the whole process becomes infected. This can be brought on by prolonged rupture of membranes. We have talked about when the water breaks, how the time clock starts. And we're really concerned with babies when that time clock starts, but it's also an infection for the mom as well, and especially in an abortion situation. If her membranes are ruptured and we don't know about it, and that is just an avenue for infection, and moms can get really sick. So anyways, these septic abortions also can be caused by, the back alley garage coat hanger abortions. So we need to find out, for whatever reason this woman is bleeding, we need to find out why. So we can either do an speculum exam, we can do an ultrasound, we can do some lab studies to confirm if this is a pregnancy, but it does not, of course, tell us whether the baby is alive or not. The ultrasound will tell us that. We do the H&H on mom. So if we do have a woman that is bleeding and we have determined that the pregnancy is still viable, then we will put her on bed rest until this bleeding has resolved, if it does resolve. If the bleeding persists and it's determined that the abortion is imminent, or if she's had the abortion but it's incomplete, then we will need to help her with her bleeding issue. So we bring her in, IV fluid, maybe even blood transfusions. We might have to do a D&C. And then also, we have to do a RhoGAM. So, if mom is Rh negative. If mom is not Rh negative, we don't need to worry about it. But if mom is Rh negative, we need to do a RhoGAM. We need to assume that that baby was Rh positive. Okay, so the baby's gone. We don't know what the baby's Rh was or would have been. So we need to treat mom anyway. It's not going to hurt to treat her anyway, but what's going to hurt is to not treat her. That baby indeed was Rh positive, and then she gets pregnant again with another Rh positive baby, and now we have a problem. So a missed abortion is so the products of the conception eventually expel spontaneously, but if they don't, within 4 to 6 weeks, we need to do something about it. And like I said earlier, I don't like the idea of waiting 4 to 6 weeks. But if we have to go in and help this woman, if she's had incomplete abortion or a missed abortion or whatever that problem is, then we need to do the D&C, the dilation and curettage, okay, to evacuate the uterus, okay. Depending on the gestational age, we might even actually do like a labor induction to get her to pass this baby. Or like the D&C, the dilation and curettage, it's a surgical procedure where they dilate the cervix and they go in with a little curette, little instrument, and they scrape the uterus, the inside of the uterus, so they scrape out all the products that are in there. The D&E, dilation and evacuation, is pretty much the same. It's a surgical procedure where we dilate the uterus and we go in and we pull out the pregnancy. Okay, so these are later in later gestational age. All right. Other common causes of bleeding during pregnancy, here are 4. Ectopic pregnancy, gestational trophoblastic disease, placenta previa, which we have talked about, and abruptio placenta, which we have talked about. So, for the ectopic pregnancy, so this is a pregnancy that was fertilized. However, the implantation is not in the uterus. It's in some other part of the body, and usually it's in the fallopian tube. Most of the time it's in the fallopian tube. However, it could be in a lot of other different places, and I'll show you that. So, initial presentation is of normal pregnancy, but as the pregnancy progresses, things don't seem to be feeling right. So, as that pregnancy progresses and that embryo starts growing in the tube or in the other part of the body other than the uterus, then that starts creating pain. And if the pain is ignored and it continues to grow and continues to grow, it can rupture the uterine tubes, the fallopian tubes. It can cause bleeding in the perineal cavity, peritoneum cavity, and it's just a bad scenario. So here is a diagram of all the different places that an ectopic pregnancy can occur. So we have ectopic pregnancies in several different places within the fallopian tubes. You can see that that ligament between the fallopian tube and the ovary. That is indicating that could be a spot for implantation. Right on the ovary can be a spot for implantation, and look into the abdominal cavity. So somehow we get that implantation inside the abdominal cavity. So these can be bad. So the signs and symptoms that the woman is reporting is severe pain on one side. Okay, she can complain of syncope. She can complain of referred right shoulder pain, lower abdominal pain, fallopian or ovary tenderness, or tenderness in the area of the fallopian tubes and the ovaries. She could be bleeding, so you would have a decreased H&H, and then as the body tries to take care of this abnormal implantation site, you will see increased leukocytes. So we need to get a menstrual history. We need to do a pelvic exam, even an ultrasound. We need to do HCG measurements, and then it might require laparoscopic interventions, which is typically the way that we would go and remove that pregnancy. So there is a medicine that can be given that interferes with the proliferation of the trophoblast. So if you remember from first semester PN or second semester PN, when we talked about how the baby develops, the first part after fertilization is that trophoblastic proliferation, which develops into the placenta and the amniotic membranes. So this interferes with that. So then the fertilized ovum cannot progressively develop if we interfere at this stage. But typically we do this laparoscopic procedure where we go in and we cut this out of the tube, or try to retrieve it where if it's in a weird funky place. Okay. Either way, we need to do our RhoGAM for this mom if she is Rh negative and non-sensitized, because we don't know what the baby is. We don't know if the baby's positive or negative. So we just do this kind of prophylactically just in case. It's not going to cause a problem. Now, our other bleeding issue is gestational trophoblastic disease. Okay, so this is an abnormal proliferation of those trophoblastic cells. Okay, so there's a few different types: hydatiform mole, invasive mole, and choriocarcinoma. So what happens is we had something fertilized, and the trophoblastic cells just proliferate abnormally, and it really just looks like a bundle of grape clusters, but they're blood-filled sacs. Okay, the pregnancy is not viable, and in the future there is a possibility that because of this she could develop a choriocarcinoma. Now, there are two different types of hydatiform mole. That's a complete and a partial. Either way, they're not viable pregnancies. But here we go. So the complete mole is, excuse me for a moment. All right. So a complete mole is we have an egg or an ovum, but there is absolutely no genetic material in it. It is an egg. So here comes the normal sperm, and it fertilizes that empty egg. Now the partial mole is kind of similar. So we actually have a normal egg, okay, and it's fertilized by either two sperm, so that makes actually 69 chromosomes. So we have two sperm. Each sperm has 23 chromosomes. The normal egg has 23 chromosomes, and that totals 69 chromosomes. That's incompatible with life. Or, so that's two sperm. Or we have just the one sperm that failed to undergo meiotic division, and it still contains 46 chromosomes. So when that one sperm with 46 chromosomes fertilizes the normal egg with 23 chromosomes, we still end up with 69 chromosomes. Okay, so that is not a viable pregnancy. Okay, now the third type of gestational trophoblastic disease is an invasive mole. It's similar to the complete mole, but this actually penetrates or involves the uterine myometrium. Okay, and then the choriocarcinoma, the third type, is a malignant cancer in the uterus that stems from abnormal cells in the developing chorion. Okay. All right, so here's just a picture of a hydatiform mole. It looks like a bunch of grape clusters, but these grape clusters are actually blood-filled, and these are what, I mean, she can pass blood, but she can actually pass blobs of these clusters. Okay, so of course we have vaginal bleeding. We have uterine enlargement because that is growing and becoming bigger and bigger. We pass these grape clustery looking things. She could have hyperemesis. She certainly will have anemia because of the blood loss. And then we try to listen for heart tones, and there are none. So we diagnose and treat this. First, we diagnose with ultrasound, and then we treat it with a DNC. So we just try to, or a suction evacuation. We can use uterine, the curettage instrument as well. Guess what? We're giving this woman RhoGAM because we don't know if this woman is Rh negative and not sensitized. We don't know what the baby is or what the products of this hydatiform mole would be. So we will give her Rh, or we will give her RhoGAM. Now, if she's at increased risk for developing this choriocarcinoma, it might be safer for her to get a hysterectomy, unfortunately. Okay, so so the malignant form, so they're at 20% risk of developing the malignant form. We do baseline studies. We do sero HCG measurements. We follow this woman closely and determine her risk. So we might have to do a hysterectomy in those cases. So if she's not able just to luckily pass this molar pregnancy without problems, and she needs admitted to the hospital, she may lose a large amount of blood. If we need to go to surgery, we need to have cross-matched blood available. We will need to give oxytocin to help her uterus contract. And then, of course, like I said, we will need to give her RhoGAM. Okay, so that's the end of our bleeding problems in pregnancy. Now we're going to talk about hyperemesis gravidarum. So hyperemesis gravidarum is persistent, continuous, severe, nonstop nausea and vomiting, no matter what, and then when you've thrown everything up, you have uncontrolled dry heaving. It causes tremendous weight loss in the pregnant woman. This is in the first trimester. Usually, in rare cases, this can last throughout the entire pregnancy. We have actually had a few patients at CMC where this lasted throughout the entire pregnancy, and I'll use them as examples as we proceed through these slides. But the woman, absolutely, I'm telling you, this is not just your normal morning sickness up to 16 weeks. This is persistent, continuous nausea and vomiting. There's nothing she can do. She can't even look at water without vomiting, okay? Now, why does this happen? Who knows? It might be related to elevated estrogen levels. It might be related to elevated HCG levels. It might be related to GI hormones that are overactive because of pregnancy. Irregardless, this is a problem, and this is what it causes for mom. So severe dehydration, possible starvation, hypovolemia, hypotension, tachycardia, increased hematocrit because of her dehydration, decreased urine output, metabolic acidosis, all these things, muscle wasting, and she can lose the pregnancy because she is not getting any nutrition, and neither is the baby. So our goals are to somehow control the vomiting, to treat and correct dehydration, restore electrolyte balance, and somehow provide nutrition. But how do we do that if she keeps vomiting? So she can be outpatient therapy, but a lot of times these women are admitted for a while. IV fluid, so that's just hydrating, and then if we have electrolytes in our fluid, then we can help restore her electrolyte balance. But then we would be also giving medications to try to stop the nausea and vomiting. And here are several different medications that we can try. And then if this woman is absolutely not able to take any PO nutrition, then she might be started on total parental nutrition, or TPN. And the two patients that I'm thinking of from CMC, they ended up with PICC lines. Actually, I'm trying to think if one of them actually ended up with a central line. I think one of them actually ended up with a central line. And we were giving TPN. They were at home, and the home health nurse would go and administer their TPN. So anyways, so like this slide says, so like this can be done at home, okay? All right, moving on to hypertensive disorders. Love these things. So hypertension. So there's several different ways a pregnant woman can present with a hypertensive problem. It is preeclampsia or eclampsia. It is, well, preeclampsia. Eclampsia is more specifically seizure activity because of severe preeclampsia. Chronic hypertension, so she could have hypertension before she's ever even pregnant, and she still has the hypertension, of course, when she becomes pregnant. Or chronic hypertension with superimposed preeclampsia. Yeah, that's a thing. And then gestational hypertension. So what are the differences in these? Well, actually, first, let's talk about the pathophysiology that is going on with preeclampsia. Because, for one, they're not really sure what is actually causing preeclampsia. But they know kind of somewhat what's going on in the body. So, we have hypertension. With preeclampsia, we have hypertension. We do have vasospasm. And we do have endothelial cell damage. Okay? And these are the things that we're kind of connecting it to. So, we start having a gradual loss of resistance to angiotensin II. Okay? So if we're not resisting angiotensin II, then angiotensin II is allowed to run rapid in our system, and angiotensin II is elevating our blood pressure. Now, we also have a decrease in prostacyclin. Prostacyclin is a vasodilator and a platelet aggregation inhibitor. Okay, so if we don't have this substance, then we're not going to vasodilate. We may just vasoconstrict, which will increase our blood pressure. We're not going to have platelet aggregation inhibition. We are going to aggregate our platelets, which is going to increase the viscosity of our blood and cause and contribute to high blood pressure. We also nitric acid, or hold on a minute. I've got this spelled wrong. Hold on. Nope, I don't have this. I'm sorry. I don't have this spelled wrong. Anyways, nitric acid. So it's a so nitric acid is a vasodilator. So we have decreased levels of nitric acid. So we're not going to be vasodilating like we're supposed to. Now, thromboxane, which is a vasoconstrictor and a platelet aggregator, starts dominating our system. So it's going to start causing us to vasoconstrict, and it's going to start causing platelet aggregation. Okay, so all those things are happening that contribute to our hypertension, our vasospasms, which happen in preeclampsia, and our endothelial cell damage, which happens in preeclampsia. Now, the other things that are going on is because of this hypertension, we have decreased renal perfusion and a decreased glomerular filtration rate. So we have the decreased renal perfusion, so we have decreased urine output, and we start retaining sodium, which leads to increased extracellular volume, which is why we see edema in preeclamptic women. The other reason why we see edema in preeclamptic women is because of the endothelial cell damage. So we're damaging our vessels, which is allowing fluid to leak out and third space. So those are all contributing to our edema. Now also, because of our increased sensitivity to angiotensin II, so our sodium retention, increased cellular volume now contributes to our increased sensitivity to angiotensin II, which is what causes us to be hypertensive. Okay. We also now, because of our glomerular filtration, we are increasing levels, or serum levels, so we're retaining creatinine, BUN, and uric acid. So we can do serum lab values and see that those creatinine, BUN, and uric acid are increasing above normal. We also have increased albumin excretion, so we're getting rid of albumin, which leads to decreased serum albumin levels. So we can test our albumin levels and see that they're low, all right? Which leads to, so our decreased serum albumin levels leads to decreased plasma osmotic pressure, which leads to increased extracellular fluid, which leads to edema. So we have all these mechanisms that are contributing to edema. Now, with the hypertension, vasospasm, and endothelial damage, we're now having decreased placental perfusion, which causes our baby problem. So we have the fetal growth restriction, decreased fetal movement, and we have a hypoxic, stressed baby. Now, with the decreased intravascular problem, we now have an increased viscosity of our blood, which we could see in elevated hematocrit levels. Okay, so that's a long story to tell us about some of the things that are going on in our body when we have preeclampsia. Now, so old school, we separated preeclampsia into mild or severe. People are not liking to say that anymore, so a more politically correct way is to say we have preeclampsia, period, okay? But we have it without severe features. So when we have quote-unquote mild preeclampsia, we discuss that or term that as preeclampsia without severe features, okay? So edema is no longer, edema used to be diagnostic. So if the woman had elevated blood pressures, proteinuria, and edema, then she was diagnosed as preeclampsia. But edema is no longer diagnostic. However, many of these women do have edema, some severe edema, but also pregnant women who don't have blood pressure issues have edema as well. So anyways, the blood pressure for preeclampsia without severe features is greater than 140/90. And then she has proteinuria, which is greater than 300 milligrams of protein in a 24-hour urine. Now, if we just did a urine dipstick, which we don't do on the inpatient clinics or on the inpatient floors anymore, we because of some JACO rule or something unrelated, some rule that says that unless we can do the controls in our units, we can't do urine dipsticks. But anyways, I digress. So if we did a urine dipstick, which they can do in the doctor's offices, it would be a +2 protein on a urine dipstick, okay? And then this is not diagnostic weight gain, but we will probably most definitely see weight gain with women who have preeclampsia because of edema. All right. Now, back in the old days, we called the worsening preeclampsia as severe preeclampsia, but we don't do that anymore. What we say now is preeclampsia with severe features. And those severe features are blood pressures greater than 160/110. Okay? Proteinuria greater than 5 grams in a 24-hour urine, or a +3/+4 protein on urine dipstick. In addition, she will now have oliguria with a urine output of less than 500 cc's in a 24-hour period. Okay, so what are the signs and symptoms of preeclampsia with severe features? So these are the things the woman will be complaining of. Vision or cerebral disturbances, pulmonary edema. So she doesn't really complain of pulmonary edema. So she'll complain of shortness of breath or something like that, or she can't catch her breath or doesn't feel like she's breathing well, and we will diagnose pulmonary edema. So she will complain of epigastric or right upper quadrant pain, and that is referring to liver involvement. So she has impaired liver function. So when we do her liver function studies, we will see elevated liver enzymes. She will start developing thrombocytopenia, or she will demonstrate, we will see evidence of hemolysis, okay? Bleeding, basically. Bleeding from the nose, bleeding from the ears, bleeding from sores on her arm, bleeding from anywhere she could bleed from. We will see intrauterine growth restriction. We will see hyperreflexia. So normal deep tendon reflexes, or the reflexes that you would get using the hammer on the knee tendon, usually +1, +2, normal. Hyperreflexia is greater than is +3 or greater. Okay. We will see clonus. So, oops, I'm sorry. Oh wow, where'd I go? Clonus. So what clonus is we take a foot and we slowly flex her toes towards her upper body. Like, we're not hyper flexing it, but we're just flexing her toes up to her body. And what will happen in clonus is, once we've done that, the foot will bounce. Okay, it'll bounce one time, it'll bounce 2 times, and that's clonus. So if it bounces 1 time, we say she has 1 beat of clonus. If it bounces twice, 2 beats of clonus. 3 times, 3 beats of clonus. Now, also included in severe features is HELLP syndrome. So this is very, very, very bad if she develops HELLP syndrome. HELLP syndrome is a mnemonic, or HELP is a mnemonic for hemolysis, so she's bleeding everywhere, elevated liver enzymes, and low platelets. Okay? All right. So eclampsia is now she's having a grand mal seizure because her blood pressure is through the roof. All right? Okay, so that is a quick overview of eclampsia, preeclampsia. The one thing I do want to talk about is, oh wow, I don't want to go there yet. So when we admit patients with preeclampsia, we usually start them on a drug called magnesium sulfate. It's an IV drip medication. It is a very, very dangerous medication. It's a black box drug. It requires 2 RNs to verify the rates. We run this very well. We start this drip with a bolus that we run it in very fast for 20 minutes. And then we put them on a maintenance dose. So our bolus is a 4-gram dose, run in 20 minutes. Our maintenance dose is a 2-gram per hour or dose. So it's a smaller dose. We give magnesium sulfate to protect this woman from a seizure. That's why we give the drug. It does have a side effect of lowering blood pressure, so great if it does. That just helps us out. But we do not give magnesium sulfate to lower blood pressure. It's actually a side effect. And it doesn't, sometimes it lowers it great, and sometimes it doesn't lower it great at all. And then if she starts developing, so if has preeclampsia without severe features and she's preterm, we might keep her until she is term if baby looks okay and she does not develop severe features. But if she starts developing severe features, then we may need to go ahead and induce her, even though she may be preterm, because it would be safer for her and baby to be not pregnant anymore. All right. Oh, I'm sorry. Like, we just talked about eclampsia here, so let me go back. So that was eclampsia, preeclampsia, eclampsia. Chronic hypertension is just that. This woman had hypertension before the onset of pregnancy, and it, of course, continues throughout pregnancy, if that's all that occurs. Or she could have chronic hypertension with superimposed preeclampsia. So what that means is she develops proteinuria, right? So she has the high blood pressures, she has the proteinuria, and depending on if she's with or without severe features, she may be developing those other signs and symptoms as well. Gestational hypertension is just that. It's a hypertension that develops during pregnancy. She doesn't have chronic hypertension, and she doesn't have proteinuria. Okay? All right. So sorry I thought I had specific slides on that. So now various infections of the pregnant woman that affect the baby. So toxoplasmosis, some of you may know, it's a bug that you can get from eating raw meat or unpasteurized milk. You can also contract it with cat feces. So a big thing during prenatal visits, is they talk to women about, do you eat raw meat? Do you eat unpasteurized milk? And do you have a cat in the house? And can someone else change the litter box? Okay. Rubella could be a problem. A woman could be immune or positive for rubella. Cytomegalovirus, so that's kind of similar to herpes, the herpes virus. Group beta strep virus, we'll talk a lot about that. And human B19 parvovirus, otherwise known as fifth disease or slap cheek disease. So with toxoplasmosis, this can really be a problem for a baby. Baby could develop ascites, microcephaly, intracranial calcifications, growth restriction, really, really, really bad stuff. Convulsions. So we need to watch and treat mom if she is exposed to toxoplasmosis, okay? So here is the treatment for mom, and then here is the treatment for baby as well after delivery. Now, rubella, so here are your risks for the baby. So baby could be born with congenital cataracts, deafness, heart defects, mental retardation or cerebral palsy, okay? So we prevent rubella with vaccination prior to pregnancy. If she is not rubella immune and is pregnant, then we just manage and watch the pregnancy, okay? Cytomegalovirus, so it can, if the woman is positive for this virus, it can cross the placenta. Baby can be exposed during the birthing process. It does cause mental retardation and hearing loss. And then there are some more listed risk factors for baby as well. And you see that, or baby could have no damage at all. Mothers typically are asymptomatic, like we don't know this unless we test for it. And there's no treatment, just like in herpes. I mean, as far as there's no cure. I'm sorry. So herpes can cause preterm labor, uterine growth restriction, infection in the neonate. So typically transmission is done at birth. If the woman is doing a vaginal birth and has active lesions. If she does have active lesions, she goes straight to C-section, and the chances of neonatal transmission are very low. Okay. However, if baby is infected, baby will probably convert. Okay. So treatment, we do put women on acyclovir to prevent outbreaks so that she can have a vag delivery, and possibly to decrease the risk of baby contracting. Okay. GBS, so this is group beta strep. So here's your risk factors for baby for group beta strep. They have respiratory distress, pneumonia, apnea, shock. This is really bad. They could get meningitis. This is really bad for babies. So if women are positive for GBS, this could be really bad for babies. Now, if women are positive for GBS, like group beta strep, it's just part of their flora sometimes. The woman is not sick from it. She's not, it's not like an STD or anything like that. So she doesn't know she has it. Half the women have it, half the women don't have it. But we do screen for it close to term. So about 35 to 37 weeks, we will screen for GBS. It's a vaginal anal swab, and then we send that for culture. We get the results back. If she's GBS positive, then we want to do antibiotics, usually penicillin if she has no allergy. We usually do penicillin during labor, not to treat or cure mom, but prophylactically for baby. Okay? Now, the question is, if this woman is planning to have a C-section, do you need to do a GBS? Well, no, not really, because if babies do not go through the birth canal, the vagina, then their risk of exposure is very, very, very nil. However, wonder if this woman who is planning a C-section all of a sudden shows up in your labor unit at 10 centimeters and you don't have time to go to the OR. So she delivers vaginally. We don't know what the GBS status is of this woman, and even if we did, we didn't have time to get antibiotics in. So baby is born, and what happens is that doesn't necessarily mean baby has contracted GBS disease, but we do need to watch that baby very, very closely for 48 hours. Pediatricians will not send babies home before 48 hours if the woman was GBS positive or if the GBS status was unknown and she was not treated. Okay? So some physicians will do a GBS on their planned C-sections, some will not. Okay? If you get a woman in labor and we don't know her GBS status for whatever reason, we will prophylactically do antibiotics anyway, just in case. Just in case she was GBS positive. But we don't want to take that chance on baby becoming infected. Okay. So parvovirus causes severe problems with baby if baby ever makes it through the pregnancy. Okay. So that's the short end of that one. All right. I've listed, so this is pretty much the end of the lecture. The next several screens are this table of some different types of maternal infections, the signs and symptoms, how they're treated, and what the implications are for the pregnancy and or the baby. Okay? So I do want you to review these. You do not have to memorize these, especially the treatments, but kind of have an idea of the different infections and what the implications could be for the baby. Okay? So there's those. I thought that was the end, but it's not. So now we're going to talk about RH, this lovely little confusing thing sometimes. So every person has an ABO type and every person has an RH type to their blood. Okay? So if there's two different types of RH, you're either RH positive or you're RH negative. If you're RH positive, that means that you have the RH antigen on your erythrocytes, okay? If you do not, then you're RH negative. So the problem is that if an RH negative person is exposed to RH positive blood, then they will develop antibodies against the RH antigen, okay? So, for instance, if an RH negative person received a blood transfusion of some sort that was RH positive, then she's going to develop antibodies. That's pretty rare. What typically happens is this woman gets pregnant. I may be jumping ahead, so let me see. Okay, so what typically happens is the Rh negative woman carries has her first pregnancy, and it's an Rh positive baby. Okay, so she becomes exposed to those Rh positive cells either at delivery or during some sort of abortion, termination. It could possibly happen during an amniocentesis or some kind of trauma to the woman's abdomen that causes a bleed. Okay, so an Rh negative woman has her first pregnancy. It's an Rh positive blood, and then at delivery or due to some event, she has become exposed to baby. So now she develops antibodies that will fight the Rh positive antigen. Okay. Now, so the first pregnancy is usually not a problem. Okay. She delivers that baby. She has developed these antibodies. Then what happens is she gets pregnant a second time. She is still Rh negative, of course. This baby is say this baby is Rh negative as well. No problems. Everything is wonderful. But if this baby ends up being Rh positive, and this woman has created the antibodies, those antibodies from the first pregnancy, those antibodies will cross the placenta in utero and attack baby's blood cells. And so that can cause severe anemia and even death for that second pregnancy. Okay? So this is kind of what happens. So if that does occur, mom's antibodies cross the placenta and start attacking baby's blood, this is what could happen. So we could cause fetal severe fetal edema, which is fetal hydrops. We can cause jaundice, a terrible jaundice, which is called icterus gravis, or we can cause neurological damage, which is kernicterus. Okay, so we can cause one or all those, or we can have all three of those, and that disorder is called erythroblastosis fetalis. Okay, so let's try not to let that happen. So we can do an antibody screen to determine if an Rh mother has been sensitized. That screen is called an indirect Coombs test. Okay, we do this prenatally. It measures the number of mom's antibodies if they're present. Okay, if there's no antibodies present, then she has not been sensitized, or the screen is, or the test is negative. Okay, and then we will rescreen again at 28 weeks. If she continues to be negative, in other words, she is not sensitized, in other words, she has not made antibodies, then she's given the RhoGAM. Okay. So that provides protection against her creating antibodies to possible Rh antigens. Okay. However, if she is sensitized, in other words, she has created antibodies, then her indirect Coombs test will be positive. Okay, and then they'll do an antibody titer to try to figure out what specifically is going on. If the antibody titer is elevated to a certain point, I'm not really sure what that cutoff is. But the lab will tell us she's either positive or negative, and then they will tell us what the antibody screen is. But anyways, we will just closely monitor the pregnancy. In other words, we will be doing fetal surveillance tests. Okay, and then she'll be screened again after delivery. Now, So to prevent sensitization on a woman who has not been previously sensitized, in other words, she has not developed antibodies, we will give her RhoGAM. Okay. Now, what do we do for the baby? Okay. So if baby has had indeed a severe anemia, then we will do an in utero. We will do an intrauterine transfusion. So we've actually done several of these at Community Medical Center, and they've been very successful. Okay, we may even have to do an early birth. Okay, a preterm birth if the if it's severe enough for baby. Okay, however, we will try to wait until at least 37 weeks, and this says fetal maturity is confirmed. That's the fetal lung maturity. So if we have a baby that's severely compromised, we have an obstetrical reason for doing a preterm delivery. So we will probably not be doing a fetal lung maturity. Now, if our mom is not positive, if she has a negative indirect Coombs test, that means she's not sensitized, she has not created antibodies, she will be given RhoGAM. If, of course, she's Rh negative and baby is Rh positive. Okay? All right, now, so if you guys have any questions about that, please let me know. Okay, so this is only a problem for moms who are Rh negative. We need to know, is baby Rh positive or Rh negative? If baby is Rh negative, we have no issues. Baby's negative, mom's negative. But if baby is Rh positive, we may have issues. We need to know if mom has already developed antibodies. If she hasn't, we need to give her the RhoGAM to prevent her in doing so. Now, the other incompatibility is the ABO incompatibility, which is really almost hardly worth mentioning because ABO incompatibilities, although they exist, it's a very rare that they cause any problems. Okay, so the issue, a Group A baby, a Group A or a Group B baby will occasionally have, be affected if the mom is type O. However, it's inconsequential. Like, we don't even notice any signs and symptoms. We don't treat this. We rarely ever see any problems for baby, it's just not a thing. We might watch this baby for a little bit of jaundice. Why? Because if there was any amount of hemolysis at all, then that is red blood cell breakdown. It causes hyperbilirubinemia in babies, which you will see as jaundice, the yellowing of the skin. But it's very mild, very super mild, very rare that it causes significant problems. And like I said, hardly even worth mentioning, but I'm supposed to because it is a potential. Okay, so we do have an exam on Sunday. Please let me know if you have any questions in the meantime. I just hate recording lectures when I'm not able to do these in class. So if you do have questions, if you're able to listen to this before you see me again, please call my cell phone or text my cell phone, okay? Because the exam is on Sunday. Okay? See you guys next week.